Hello, lovely people. Happy Thursday. You might notice the unusual background. I'm coming to you from Mount Vernon, Washington, one of the most beautiful places I've ever been to. And yes, my wife and I are taking a little bit of a road trip, but I wouldn't miss hanging out with the VMR family for really anything, especially when I get to co-discuss today with Shema, who really, really, truly embodies what it means to literally not require an introduction. Shema has been with CP Solvers for, it feels like decades, older than CP Solvers itself. And I know for a fact that her journey will inspire many, many, many people. And I think it's very, very telling and almost symbolic that Shema is discussing today after coming to some clarity about what she wants to do as a grown-up recently, which I won't share publicly, but it was really, really nice to hear that from her. And I think to honor that a little bit today, because I met Shema when she was very, very young in her clinical journey as a junior medical student who came into VMR with so much passion, so much wisdom, and really just symbolized what it mean to be somebody who's enthusiastic about clinical reasoning and wanting to share that clinical reasoning with other people. And it takes the form of so many things that she currently does, including meeting some of you in the case review committee, including being on the podcast with the subspecialty series. She's built up a lot of clinical skills and other skills, including some pretty cool audio editing skills I saw recently. Uh, so hi, Shema. We're thrilled to have you here. I'll pass the mic to you to say hi, and then we'll introduce our case presenter.
Hello, everyone. My name is Shema, and yeah, for those who don't know me, I'm a huge enthusiast for internal medicine, but I'm also kind of, as I say, hobby dermatologist, just doing it as a hobby because I feel like the whole body system is being connected. If we have something in the skin, as Rabih always says, this could be also a systemic manifestation of the disease that is going on. So yeah, and otherwise. I didn't have the best week this week. I mean, coming back from Austria and then being back in the boring city that I live in. Okay, it's not that boring, but it was not the best week. So I'm even more. I'm even more. I mean, yeah. I mean, I had the nice pleasure to meet Leah last week, and then I'm again here in the rainy Berlin. So yeah, but it's even such a pleasure to seeing you all here and discussing a case. I think my mood will be much better after that. And I'm excited because I know Noah mentioned that Nicole Zaki is going to present a very amazing case to us, and I don't have any idea. And then I would lead the mic to you, Nicole.
Hi, everyone. I'm Nicole. I'm finishing up my third year of internal medicine as a resident in Canada, in Manitoba. This is my first time presenting, so hopefully all goes well. I'm quite excited about this case. I have seen this case almost 6 months ago, and I'm still thinking about it because I thought it was pretty cool. So hopefully you guys enjoy it and enjoy working through it. I'm sure I'm going to learn a lot from you guys. Um, yeah, I think that's all I got.
Oh my gosh, no way. That's not all you got. We got to hear more. It's so nice to meet you. I feel like we've crossed paths on VMware many a time, Nicole, and I'm very excited for you to present a case today. I'm curious if you wouldn't mind telling us a little bit more about yourself outside of medicine.
All right. Honestly, this year has felt like mostly medicine because I've just written my Royal College. But I mean, I'm from Winnipeg, maybe a place not many people know about in Canada. I've grown up here my whole life. I've done my whole medical training here, and my whole family's here, which is awesome. I think some of the things I like to do outside, which I'm thankfully just getting back into, like to play guitar, which a friend had taught me many years ago. So I'm just jumping back into that hobby. Love books, love me a good binge read, sitting and reading for about 3 days, finishing a book, and then waiting months to do it again. So,
I'm sure many people will relate to that. That's so cool.
oh
Oh,
yeah.
what are your plans after? Congrats on being the end of the residency journey. When is your last official day?
So June 30th is technically the last day, but then I'm starting my fellowship in general internal medicine. So I got
Oh,
2 years of that and doing some training, hopefully in some perioperative medicine.
oh, interesting. So 2 years
Yeah.
of a gen med fellowship. What does that look like? Is it truly general internal inpatient outpatient, or is it skewed one way or the other, or what does that look like?
It's a bit of a mix. I think like here we mostly do a lot of inpatient. We do like more of a longitudinal clinic. So we pair up with one of our staff and do clinic for the 2 years with them, with our own patients, like really getting a sense of how to run a clinic. There are some rotations that we need to do to like get a sense of, how do we specifically as general internists consult on obstetric patients, perioperative patients. So it's more getting into the weeds of general internal medicine.
That's so cool. Well, hey,
Yeah.
I'm so biased. I'm a horrible mentor to many of my mentees because a good mentor would be open to them pursuing any skill or interest, but I think it's very much public knowledge that I really cannot help but steering people towards a career in general medicine because it's so incredibly satisfying. So I'm
Yeah.
so excited that Shame as a hobby dermatologist and not a hobby internist. Uh, But yeah, with that being said, I want to thank you for preparing this case. I hope that what Shema just said about Noah knowing this case is a little plug to the case review committee, who's there to help you put all your cases together, bread and butter or complex. So please, please, please consider logging on to our website and submitting a case for us to help you put it together. And without further ado, Nicole, we're ready to um, chat about your case.
All right. Also, huge shout out to Noah and Parisa. Thank you so much for helping me put this together. And with that, I will jump into the first bit. So the patient that I saw, do you want me to just do the tagline, I guess, and then I can get into the first aliquot, or?
Whatever you had prepared is totally cool by
Okay.
us.
Sounds good. So the patient that I saw a few months ago was a 31-year-old gentleman who has a probable splenic angiosarcoma awaiting surgical resection, who comes in for these disseminated cutaneous lesions that were undiagnosed at that point. I'll give you a little bit of background just on this like splenic angiosarcoma that he had. So he presented to his family physician a few months before his emerge visit with night sweats, weight loss, left upper quadrant pain. He had a microcytic anemia at that time with an elevated ferritin. He was referred to GI out of suspicion. Is there like an intraluminal cancer with a upper scope not showing any evidence of like an upper GI tract malignancy. He then went on to have a CT scan and then an MRI of his abdomen, which showed a very large splenic mass that over time was enlarging. He was referred to cancer care for further assessment, seen by a general surgeon, and after discussion with their colleagues as like a multidisciplinary meeting, they decided that, an angiosarcoma was probably the most likely. Also had a couple of other thoughts about what this like mass could be. So they, after talking to the patient, decided on surgery. So in terms of these skin lesions, though, he presented the day before his planned surgery with these worsening cutaneous lesions. They had been present for about 6 months. He's never had them before. The lesions have come and gone on his arms, his legs, his torso, and he describes them as like a pimple that grow to about a few centimeters in size. It opens and drains with fluid, sometimes blood, then it will heal and scar over. The most recent ones have happened over about a week and a half on different areas. I think his right bicep, his left dorsal hand, the right lower abdomen, and the left leg, and they're all at different stages of the process. And two of them had opened and started bleeding, which caused him to come to the hospital, to the ER, the day before his surgery. There's no like trauma, scratching to those areas. He hasn't used any like lotions or any other weird topical agents on those areas. Um, Otherwise, there's no like autoimmune symptoms, no lymphadenopathy. Besides the constitutional symptoms, no other constitutional symptoms. And otherwise, on his review of systems, he's had this chronic dry cough for like over a year now. There's no hemoptysis. He thinks it's worse in the cold weather. Um, no TB contacts, and he was tested for TB with like his immigration. He's from Pakistan originally and moved about a year and a half ago. So, and that is the end of the first aliquot.
Holy smokes, I'm so intrigued and I can't wait for Shane to share your thoughts. Thank you, Nicole, for really an explosive output and a huge shout out to Leah, who somehow was able to keep up with all that information. Thank you,
Sorry.
Leah. No, it's all good. It's all good. I think the first time case presenter velocity is hard to it's hard to work around, but especially when you have such a rich output. I'm really excited to hear hobby dermatologist's approach to this. Shema, what are you thinking?
So first of all, it's very pretty enriching aliquot, seeing we have a patient with splenic angiosarcoma. And the first thing that comes into my mind, what I learned from you, that this is one of the few very aggressive skin, tumors that can also manifest on the skin. So I'm very concerned about that. And seeing these disseminated cutaneous lesions, the first things when I see cutaneous lesions, as you always say, Rabih, the thing is it limited to the skin, or is there any systemic disease that is presenting itself on the skin with disseminated skin manifestations? And in this patient, also seeing this oncologic background, I am also concerned whether there could be some skin metastases showing in this form. Another thing that I might be thinking of, also seeing that this patient has some chronic dry cough, the exposure of this patient, he's from Pakistan. He didn't have any TB contact, but it still doesn't it doesn't exclude for me that some kind of granulomatous infection could be going on. And the other thing for me is to look how these skin lesions look like. If it's like, do they look like nodules, which could give me an imprint that this is something like an infiltrative disease and something like a metastatic disease or a granulomatous infection. But it's, yeah, I'm very excited where this case is going to lead me.
Yeah, no, I love all of that. I think that you're starting with this idea that the patient has a presumed angiosarcoma, so that's bending your analysis of the skin lesions by saying, "Hey, I'm entertaining something pretty rare, which is skin metastases with this very aggressive malignancy." But then I heard you pivot away and say, "Hey, you know what? I need to know what these look like because I also have an inlet to think about an infection given the epidemiological exposure." And I think that that's very, very wise of you to do that. And I think it just illustrates the shaky ground that we're on. And I don't think there's anything firm to stand on quite yet, because the diagnosis of any form of angiosarcoma is always presumptive until you have surgical excision. There are a few cancers that are diagnosed radiographically. I think most classically it is RCC, renal cell carcinoma, and HCC, hepatocellular carcinoma, because their vascular pattern is so characteristic. But I think that this is Nicole emphasized, this is probable splenic angiosarcoma, and the only thing we can say is this person probably has a splenic mass. And if we think of the mass from the infection perspective, maybe we can start our thinking there to try to say, okay, what if this isn't angiosarcoma? What could it be? So if you were to share your thoughts in that space, Shema, and I'll just preface this by saying there's nobody under the sun except an oncologist who has a robust approach to splenic mass. It's such a rare condition. But I'm curious, what have you accumulated in terms of what can happen in that space?
So basically, when I think of splenic mass, I mean, I'm thinking of infiltrative disorders, something like amyloid, but also, especially as you say, there are several oncologic things like I think melanoma is like one of the few cancers that can spread into the spleen. Otherwise, yeah, the angiosarcoma, what was being mentioned. I was also thinking of infections, especially in terms of something like infective endocarditis that can show up with wedge-shaped infarcts. But yeah, that would be my initial approach on that.
Yeah, no, I think that's very wise. Whenever you think mass, you should think malignancy, 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 and then other. And in terms of malignancy, the only progress you can make with spleen is just to recognize that solid tumors are very, very unusual in the spleen, and they would be exceptions rather than the rule in terms of metastasizing to the spleen. So you'll find cases of melanoma, you'll find cases of RCC, but you're really going to stretch your thinking to find a metastatic tumor going to the spleen. And that's why primary splenic tumors, such as lymphoma uh, um, and angiosarcoma, are on the hook here. The reason the spleen is big and maybe it adopts a mass-like form in other hematological diseases like leukemia is not because the spleen is infiltrated by, thank you so much, infiltrated by those tumors, but rather there's extramedullary hematopoiesis that's triggered by leukemia or myelofibrosis or things like that. But yeah, I think in this person, we have to entertain the possibility of a splenic infection. And those really take the splenic infections take two varieties when they're chronic, either endocarditis with abscess or a granulomatous infection. And I think that's where the lungs come into play for sure. Just to complete the conversation, can you think of any autoimmune diseases that affect the spleen in this way?
In this way, I mean, I would have thought of things like IgG4 related disease. I feel like it's always it can do anything. I mean, otherwise, thinking of autoimmune diseases that present with a large spleen, I was otherwise thinking of something like Felty syndrome.
Uh-huh.
And I know that Still's disease can also present
Yes.
with large
Nice.
spleen.
Nice.
And I think the whole spectrum of these histiocytic disorders generally
Yes.
can present with splenic mass.
Yeah.
Yeah.
Excellent. Excellent. It's crazy to see that you have such a robust approach to all these things. It's kind of mind-boggling, to be honest with you. I do think, Shema, that it is the exception rather than the rule to find a mass-forming autoimmune disease. Most autoimmune diseases don't form masses, and I think you've named some of the exceptions, especially the histiocytic diseases. And I think the question for us is, should we approach this as a case of splenomegaly, or should we approach this as a case of a splenic mass? And I think we're much more comfortable with splenomegaly, but I wonder if the label of a splenic mass is more accurate. So, for example, Felty syndrome, splenomegaly, mass, Still's disease, splenomegaly for sure. Mass, I don't know. And so it just goes to show you that these things are on the spectrum. And I truly don't know the answer if these things can form masses. But if I were to take your list and I would say, okay, which one would I most likely believe to cause a mass? I would then think the histiocytic diseases over the other ones. But we'll wait and see. Uh, and yeah, I think we talked so much about this first aliquot. Why don't we get a little bit more information from Nicole and we'll go forward.
Sounds good. All right, I promise the other aliquots are shorter, but I'm also loving this so far. Definitely these things were not going through my mind at 9 p.m. when I was seeing this patient, so I'm learning a ton.
Probably a good thing,
Uh,
not a bad, yeah.
So in terms of a little bit more history about this guy, so his past medical history, pretty healthy guy overall. Like he has this splenic mass that we talked about that has been worked up by a surgeon in cancer care. His upper scope that he had just showed some chronic inactive gastritis that was mild, but no like cancers, no H. pylori. And then he had a COVID infection 2 years before. In terms of his medications, he's just taking some PRN cough syrup and some Advil. He's not on any sort of like systemic treatment for his presumed angiosarcoma. There's no chemo, no immune checkpoint inhibitors that he's received. He's got no allergies. And then in terms of his social history, so he, like I said, is from Pakistan and immigrated to Canada about a year and a half before this presentation to hospital. He hasn't traveled anywhere else outside of Pakistan or Manitoba. He was living alone in Winnipeg, worked as a tech for a mobile service company, but he's been off work recently because of his illness, and he is a lifelong non-smoker, doesn't drink, doesn't use any other drugs. And that is the end of aliquot 2.
I just saw a dear friend type in the chat who I think is joining VMR for the first time. Hi, Andrew. It's so nice to see you. Thank you for joining. Um, Shema, what thoughts are crossing your mind?
I have to say, I wasn't expecting this kind of social and travel history. I would have thought we might get a little bit more, something like whether there's some kind of sexual history or some exposure to animals, but I see nothing. And that's like, I'm just trying to sort what could be the cause here. Like in this case, past medical history is really not contributory, the medication also not. I mean, the patient is from Pakistan, and important for me would be to know which, especially infections, are prevalent there. I mean, for sure, I think TB, of course, is prevalent there. I would always keep that in mind because we were talking about histiocytic disorders that can present with splenic mass. Otherwise, seeing that this is also going on for so many months, I mean, I'm still thinking of the oncologic category for sure because this has been going on for so long. I feel like, I mean, with this process of 6 months, I mean, for sure, fungal infection and also these atypical bacteria, especially the granulomatous, can present with this presentation, but still it would be important for me to know how this patient has been living in Pakistan. Has there been any kind of animal exposure? The sexual history would be important for me. And yeah, that's what I have been thinking of so far.
I have absolutely nothing to add. And I think that like knowing what environment the patient in is so important for all the infections outside. As somebody who grew up and spent 17 years in Pakistan, I will tell you the most common infection is viral gastroenteritis, proven to me every 3 months over and over and over again, though the food was totally worth it. Yeah, I have nothing to add. I think we really, really need to thoroughly examine this person's epidemiological history. But I think what you said is so true. You'll look at those skin lesions and you'll have so many more hypotheses. Because if they look like ulcers, you probably will say, hey, is splenomegaly and ulcers Pakistan? Is there visceral leishmaniasis in Pakistan? I know we've had cases from India. Does it extend into Pakistan? Or if they look nodular, you might think, oh my gosh, is this TB? Yes, there is TB in Pakistan. So I really cannot wait to examine these lesions and then go back and really try to thoroughly analyze this background history. All right, Nicole, Mike, to you.
All right. Unfortunately, I do not have like the sexual history or like how he was living in Pakistan before. There were no animal exposures, as far as he could tell me, but I can move on to the physical if you guys are ready for that. Yeah. Okay. All right. So in terms of his exam, he looks comfortable. He's a well-appearing gentleman in the emerge there. He has a heart rate of 110, respirate of 20. His BP is 142/94. His oxygen is 97 on room air, and his temp is 37.1. I'll get to the skin exam last because it's the most interesting part, but there was no alopecia, conjunctival injection, no oral ulcers, no lymphadenopathy in like the neck region. Cardiac and respiratory exams were unremarkable. He did have some discomfort to the left upper quadrant on exam, but not particularly painful. There's no signs of peritonitis, and otherwise his abdomen was soft and non-tender. And then in terms of the skin, so he had an abscess to the right bicep and the left shin. They were about 3-4 centimeters in size. Each were like open with some mild bleeding and purulent discharge with surrounding warmth and erythema. He then had a like 0.5 centimeter flush colored nodule over the dorsum of the left hand with a little bit of surrounding erythema, but not open, not draining anything. And then he had like a firm subcutaneous nodule over the right lower quadrant that was slightly tender to palpation. And I do have some pictures that I can pull up as well, because I feel like that's, oh, this will stop others share screening. Oh, oops. Am I allowed to share my screen for a second? Is that okay?
Absolutely, please go for it.
Okay. Didn't want to cover all the hard work of the scribes.
Thank you. You're too kind.
Okay. Can you guys see this right now?
Yes, yes, we can.
All right, so this top left one is the shin, the left shin there. This one on the right was the bicep. And when you're ready, I can scroll down. There's 3 other ones.
Yeah, we can
Okay.
look. Yeah, thank you.
Okay, this was the right lower quadrant of the abdomen. And then I think this was near the right axilla or like chest wall there.
Yeah.
Okay. And then last one, that was the hand there.
Wow.
Can make it a little bit bigger. So these were all like at the same point in time, all kind of at different stages of this process he was describing before.
Fascinating.
All right, stop sharing.
Nicole, I just wanted to thank you. This is this is so educational, and I really appreciate the subtle thing that you did, which is to really give us the context with which these lesions were present from the beginning. I think that really enriches the conversation. I'm really excited to get your thoughts, Shema. What did you think of those?
So first of all, Nicole, thank you so much also for sharing these images with us. So seeing that this patient is presenting with nodular skin lesions, and I know our dear Rabih G has an amazing approach on that. And first of all, also seeing these abscess formation on the torso, and there's one pearl that I learned from Rabih, that is, if you see an abscess on a torso, it is more likely to be an inside to outside job and not an outside to inside jobs. Like we learned that several infections, something like granulomatous infections, can present with something like empyema necessitans, like actinomycosis, but also TB. And these nodules, general tell me, okay, we see that this patient has a systemic imprint, and it's most likely to be something infiltrative. So it could be a granulomatous infection or even malignancy, but seeing this pus coming out, draining, it is shifting me more into an infectious process, not really malignancy. And so, and what Rabih also mentioned, like leishmaniasis is prevalent there, one of the most notorious granulomatous infections that can also present with a very, very large spleen. Like there are a few bugs that are associated with a very large spleen, and leishmaniasis, visceral leishmaniasis is definitely one of them. So I would keep that in mind. Otherwise, I would definitely think also of granulomatous infections that can also present with something like that. I don't know whether melioidosis is prevalent in Pakistan. I mean, but also just to keep that in mind, like as a TB mimicker, when patients have exposure to soil. And yeah, that's what I'm thinking so far. And otherwise, also always think of nocardia and the endemic mycosis in America. So yeah.
Oh, I think that's your differential diagnosis for the infections was superb, but what I think was more superb is now that you're saying this person who they're telling you has a angiosarcoma, you're casting doubt on that, and you're saying, hey, I'm leaning more towards infection. I think that high level clinical reasoning it requires so much more knowledge than the already high level knowledge you're displaying about the individual granulomatous infections. And I agree with you. I think whenever you see purulence, the probability of an infection skyrockets. Um, and so I think you might then force yourself to say, because the radiologists are confident enough to think this is a angiosarcoma, can I marry the existence of a cancer with the development of an infection? And I think that that relationship is very strong in general with cancers either causing a local immunodeficiency by obstruction or a systemic immunodeficiency, often through the route of treatment like chemotherapy, but sometimes through hematological consequences like hypogammaglobulinemia and other cancer-related issues. But I think if you try to force that with angiosarcoma, you don't meet a collision. But if this turns out to be a splenic lymphoma, I think hypogammaglobulinemia and subsequent recurrent bacterial infections by Staph aureus become a very plausible diagnosis. But I agree with you that simply just affecting the skin without sinusitis or pneumonia would be very, very unusual. And so I think we're either having to say, hey, this person has recurrent regular, so purulence equals infection. These infections are regular old infections, and they're happening because of an immunodeficiency that the clue of that is the splenic mass, or this whole process is infection, and we should discard the idea that this is an angiosarcoma and that there's an infection affecting the spleen and the nodules. But I will challenge the infection equals purulence and share with you that there are some autoimmune diseases that will fool you in this way, especially in the skin where you see purulent-like material, but it turns out to be a non-infectious condition. So does that trigger any autoimmune diseases that you would think of here?
I mean, what I was thinking of was
Yeah.
something like, I think, Rosai-Dorfman disease
Uh-huh.
can present like that. It's not a very common one, but I've once seen a case like that. And IgG4 was also like one of the differentials. But yeah, I have to say, I would need more clues right now because
Yeah.
I feel like my brain is empty.
No, I think that what I can do is install one small bridge, and I think it will open up the floodgates for you. Remember that pus is not from the bug. Pus equals neutrophils.
Oh yeah, the
And
neutrophilic
now
dermatitis.
Shema will be unleashed.
I am so sad. Oh
No, but
God.
that this is why we do this, right? Is like all our neurons need strengthening or reinforcement. And so I just said one sentence to you, but I think you will share many thoughts now.
And of course, Sweet syndrome, pyoderma
Yeah.
gangrenosum are
Yeah.
yeah.
Yeah, absolutely superb. So the whole family of neutrophilic dermatosis becomes really important to think about here. and this is a tension that we've lived in VMR before. Purulent nodules, infection, or neutrophilic dermatoses. That's I think the simplified version of this case. Purulence equals infection or neutrophilic dermatosis. And I think, Shema, the tension that I'm feeling right now is, could this be a paraneoplastic phenomenon affecting the skin? Or could this be a pure infection? But I will share with you that there are very classic neutrophilic dermatoses, and then there are some secondary ones. I forget if you were there in the Academy VMR we were having about the classic spondyloarthropathies like psoriatic IBD, and then the unusual ones like PAPA and PASH. Were you there for that, or no? Okay. I was going to try to pull it up now because I think you said every infection we should be thinking about. And my goal is to just to have a thoughtful analysis of, I can't find the schema version of it. I think it's worth it. So just give me 1 second as I try to search. I think I just found it. Okay, all right. So here it is. Remember, this is a patient from Pakistan with many exposures to granulomatous infections. So what are we doing here? We're installing our second phase of the workup. The first phase of the workup is infection, infection, infection. But it's always important, especially when you're confident about what phase 1 will be, granulomatous infections, to prepare for stage 2. Why would we prepare for stage 2? I would emphasize that it's the long-standing chronicity of this problem that and the relatively well appearance of this person makes us cast doubt on the high confidence of finding an infection. So where would our second landing spot be? It would be here. So Shema, you already said the skin predominant neutrophilic dermatoses. Take a glance at the systemic ones. Stills you mentioned. Vexus is probably not at play in a young person. Schnitzler's, aseptic abscess, and secondary suites, which we just talked about. And things that live between the skin and the systemic are things like Bichette and Sappho. When you look at this, do you see any high compatibility with spleen and nodules on the skin?
I mean, you mean out of the systemic ones?
Yes. So if we look at the systemic, and we here know that the patient has a systemic involvement by virtue of the spleen, can you merge any of the spleen? You mentioned one of them in particular before, Stills. Any other hypotheses come to mind?
I mean, I still don't exclude something like, as you mentioned, some secondary suites, some
Yes.
paraneoplastic process.
Excellent.
Yeah, that would be like my clue in this case.
Yeah, agreed. So I think if we look at this list and we say, okay, Stills, splenomegaly, splenic mass, maybe not. Schnitzler's is usually an urticarial rash. Secondary suites we mentioned. Vexus, too young. What do you know about aseptic abscess syndrome? Have you heard of it before?
I have not heard this term. I don't know. Is it similar to cold abscess? But I'm not sure. I would need help.
Actually, I'm not sure what cold, can you explain what is cold abscess?
Um, I only remember cold abscess when we once had a case of I think it was actinomycosis.
Oh, yeah.
Exactly. So when you see an abscess, it doesn't really look an abscess like an abscess because we don't see this typical swelling or the inflammatory nature of this abscess. But
Aseptic abscess is a little bit different. It is a fascinating condition. I think we should probably park our thinking around in the world of infection for now. If that is not leading us in the right path, I will try to ask you just to show us how you learn things in real time, like how you Google or whatnot, and share with us what you learn if it becomes relevant. But I think the two systemic conditions that are relevant here are Still's disease um, and aseptic abscess. And since you haven't heard of it before, if it becomes relevant, We'll Google it together and see what we come up with, okay? Awesome. Okay. All right, Nicole, tell us more, please.
All right. So, sorry, just getting my thing back. There you go. So, moving on to investigation. So the electrolytes, extended electrolytes were all normal. Renal function, urea were normal. As creatinine was 60, which here normal is 44 to 106. Had a low albumin of 23, with the normal being 40 to 60. He had an ALT of 42. AST wasn't done on admission. ALP was 220 and GGT was 105, with a bilirubin, the total bilirubin of 6. He had a hemoglobin of 96 coming through the door with an MCV of 74.3. His white count was 12.6 and his platelets were 462. They had blood cultures drawn, which were eventually negative. And then they had a wound swab that was done that was pending. They got a chest x-ray on admission, which didn't show any pulmonary or cardiac abnormalities. And because of the shin lesion on the left, they got a tib-fib x-ray, which didn't show any bone or joint destruction or abnormalities. And then they also got a serology for like hepatitis and HIV, which all came back negative as well. And that is the end of the fourth aliquot.
Awesome, Nicole. Thank you so much. So, Shema, what did this do for you?
So first of all, I would like to tackle the hemogram. So we see that this patient has a microcytic anemia. My approach for microcytic anemia, like thinking of the most common things like iron deficiency anemia, but also anemia of chronic disease. I think that this might be anemia of chronic disease, but still we need the iron panel as always, just to know whether the patient is also bleeding. And with the chemistry, this alkaline phosphatase, like it was interesting, Nicole, hearing from you that there is no sign of any bone destruction or anything with the bone ongoing, because otherwise, if there was some bony pain, I would relate the elevation of alk phos to the bone. But I think maybe I'm not sure whether we also have something in the liver, because I see the patient also had right upper quadrant pain, and this mildly elevation of alkaline phosphatase could be also this imprint of an infiltrative disease. So in the liver, that can also present with this elevation. And the low albumin, we always also tackle it like, is it the liver that is not producing enough albumin? Do we lose it through the kidneys in something like nephrotic syndrome, or something like protein losing enteropathy? And also, as always, inflammation, because we know that albumin is a negative acute phase reactant. So I would rather think of that, but I still can't exclude whether the patient is also losing it through the bowel. Rabih, you told me to look for aseptic abscess. I didn't have a lot of time, but I have read about the association with IBD, but I'm not sure. Just so that's why I don't know whether the patient is also losing some protein through the gut, but you would have to tell me more about it.
No, I think what you just did is you're trying to get an inventory of what this problem is by making sure that you don't just lock into this is skin and spleen. And now you're raising the question, does this person have GI involvement because of the microcytic nature of the anemia, suggesting iron deficiency, and the possibility of protein losing enteropathy? And so you're saying, wait, is this skin plus spleen plus GI? You're also saying, is this skin plus spleen plus GI plus liver? And I think that inventory of trying to understand where this criminal is going is really, really important to understand. And so I think that the tension here is if you take that MCV and you say, hey, it makes me worried about iron deficiency, we know before his ferritin was high. So now you're like, okay, is that distracting me? You also said the albumin could be from GI loss, but we don't have a UA and we know that he's inflamed, so that could be noise. So I think for me, what you've just done is to put a question mark next to GI and next to liver to see if these things are actually part of the syndrome or not. And I don't think we've gotten enough data to confirm that there is definitely GI involvement yet, or definitely hepatic involvement yet. That's because the hepatic involvement is on the initial CT was negative. So this case, the amount of data here makes it tricky to, do we update our problem representation to say skin, spleen plus lumen plus liver, or do we say skin plus spleen? And I would just summarize by saying, I think skin plus spleen is for sure. I'm putting the lumen and liver in pencil, and I'm waiting to see if I'll change it to pen or if I'll erase it, because the data there is very, very soft. How does that sound to you?
To me,
Yeah.
so it sounds amazing.
Okay, all right, sounds good. I'm glad you agree. All right, Nicole, tell us more, please.
Great. To clarify some things, because I didn't mention earlier, there were no other GI symptoms other than the left upper quadrant pain, if that helps.
Terrific.
Um,
I think we're erasing the lumen schema.
So just very short aliquot for this one. So we see the patient just as they come into the ER. We went through everything there. The patient is admitted to surgery because he's going for his surgery the next day. And the patient is started on ceftriaxone and vancomycin for these skin lesions, thinking there might be like a bacterial component to the infection. The case is reviewed with dermatology over the phone. Some photos were sent, and they thought that this might be consistent with a paraneoplastic pyodermic gangrenosum. So I'll leave it there, and then I have one more aliquot afterwards that will reveal the diagnosis.
Okay, wow. I am, first of all, mind blown by this case, Nicole. I really didn't expect that, but I mean, I think we still don't know about this splenic mass, so it would be interesting for me whether you did a biopsy of that. But I think this paraneoplastic process still makes a lot of sense, because seeing this patient developed these lesions that were coming and going, that is also very typical for pyoderma gangrenosum. And generally, I think for the whole pyoderma gangrenosum workup, what I also learned from Rabih is always like that this is there's a panel that you should order, something like ANCA, cryoglobulins, and I think there was you also had a mnemonic, Rabih, but I can't remember it. But yeah, and so I think that the tissue is the issue in this case, and this will help us and to see whether this something is persistent with consistent with pyoderma gangrenosum. I would usually take a skin biopsy at the edge of the border, because usually we associate pyoderma gangrenosum with these violaceous lesions, and usually we would expect a neutrophilic infiltrate. So yeah, we would take the biopsy at the edge of the border. Yeah, Rabih, what do you think?
I completely agree with you. I think that if you study this case and you try to analyze it from what you know this person has purulent skin lesions. Purulence equals infection. Now, what kind of infection? As you said, granuloma is the kind of infection you're looking for. So if you biopsy this person and you see granulomatous lesions, you will discard your hypothesis of the neutrophilic dermatoses. There is one kind of infection that would show up as neutrophilic infiltrate, and that's called ecthyma. It's when patients get staph or strep infections in this manner in a semi-invasive way. It's not ecthyma gangrenosum, which is with Pseudomonas, but just ecthyma full stop. And so if you biopsy this and you see neutrophils, the only infections that I can think of are staph and strep causing ecthyma. Now, that's the infection category. We have to try to say, okay, well, how does the splenic lesion influence our thinking? And if you Google Shema, aseptic abscess and splenic mass, let us know what you find when you Google that. I will just share that that's why it's so important to try to capture the problem well. And the distinction between splenomegaly and splenic mass, I think, is really key to this case. So Shema, what did you find?
That's crazy. I found one aseptic abscess of the spleen as an antecedent manifestation of Behçet's disease. Is
So
this what you were looking for?
you'll see that the aseptic abscess syndrome is a syndrome almost defined by the presence of a neutrophilic dermatosis of the spleen, basically. And it is in the family of neutrophilic dermatoses, with a tremendous amount of overlap and association with other conditions known to cause neutrophilic disease of the skin, most classically inflammatory bowel disease with erythema nodosum, with Sweet syndrome. So it is one of those diseases that lives in this family of causing sterile neutrophilic inflammation. And so the term aseptic abscess applies to patients most uh 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 I'd say most proportionally when they have a splenic abscess. It is very, very unusual to have a spontaneous splenic abscess. And so I think the moment you see that this person might have a neutrophilic dermatosis, you start to think of pyoderma gangrenosum, Sweet syndrome, IBD, Behçet's, all the stuff that we looked at. But when you start to merge that with a splenic abscess, that's where aseptic abscess syndrome comes to mind. So, if I were to try to tackle a solution to getting this person the diagnosis they need, the first thing I would do is cancel the surgery. I think it would, why? Because this phenomenon is on the spectrum of pathergy. And I would worry that the surgery might cause a lot of harm in addition to unnecessary, potentially being unnecessary. Why would I cancel the surgery? Because I can see a path to resolving this issue before surgery is needed, and surgery doesn't seem to be urgent. So what I would offer as part of a conversation with many subspecialists is to say, let's biopsy this. If we don't see a granulomatous process and we see neutrophilic disease, I would be even more concerned. And I would probably give this patient steroids because the response to neutrophilic dermatoses with steroids is very, very satisfying. And in a matter of maybe a week, you will have the possibility that you see neutrophilic infiltration, culture negative, and a response to steroids. And that may spare the patient a more potentially morbid surgery. Um, of course, you know, this is a pathway that the patient may not follow, and we may learn that he has leishmaniasis or TB, but I think the skin biopsy would be very, very important in this case. I've rambled a lot, so I'm curious what other thoughts you have, what questions you have, before we pass the mic to Nicole.
I have to say, I am mind blown. First of all, I have never heard of aseptic abscess before. And seeing this, I mean, the whole spectrum of these autoinflammatory conditions, but also seeing that how this is also being connected with vasculitis and also with these spondyline atrophies and so on. So yeah, I am very curious where this is going to be. Like, is this a granulomatous condition? Are we dealing with some, yeah, secondary autoinflammatory conditions? So yeah, Nicole, that's so exciting to know what is going on here.
Right. I was quite shocked in the end as well. So this is the last piece of things. So after discussion with dermatology, the surgeon and dermatology actually decided that this patient was safe to go for surgery. So he went the next day, got a pretty big surgery. I'll say he got a splenectomy, partial gastrectomy because the lesion was abutting the stomach. He had a partial left hemidiaphragm resection, partial left adrenalectomy. Um, Intraoperatively, plastics was consulted and they got skin scrapings. We felt that a skin biopsy, with all the oozing and like the purulent discharge, like might have been a little bit too much to do the skin biopsy. So they did scrapings intraoperatively. And a wound swab that was done the day prior, as well as those skin scrapings, returned for blastomycoses. And then the spleen pathology later came back also as blasto. There were no bacteria, AFB, TB cultures were all negative. I noticed, like looking back at the case, and this was after I had stopped following that case in the hospital, but 2 days later, on an X-ray, he actually did have evidence of a micronodularity pattern that was in keeping with blasto, whereas the X-rays from the first 2 days of his admission were read as clear and like looked less conspicuous. I do wonder if part of that was maybe the patient was a bit dry and it was like an undercall of the chest X-ray in the first place. Um, he also did have a CT that was done prior to his admission that the radiologist described as like, oh, it could be RBILD. There's like teeny tiny 1 to 3 millimeter nodules that are so nonspecific, could be like metastatic disease, could be like anything, could be nonspecific, like were nonspecific. So I thought that was kind of interesting that like eventually after his surgery, the chest X-ray now shows something when he's properly hydrated. And then we got our ID colleagues involved in the hospital. They recommended stopping the antibiotics and starting itraconazole. They recommended getting an MR of the brain just to look for other signs of disseminated disease, which showed like one area of enhancement that they're like, we can't really rule out if it's blasto. So they switched him to voriconazole. He recovered really well. I talked to the surgeon afterwards when I met him in the hospital. He said he's doing really well. He's getting a year of voriconazole, a repeat MRI that's pending to reassess that area of enhancement. And he's following up with infectious diseases as an outpatient now, and sounds like he's doing quite well.
Nicole, I
Yeah.
am mind blown, and what a humbling case. I mean, coming with that this is a fungal case. This is just amazing. And just wanted to mention again what I learned from our dear colleague Jess. He always says blasto, blast the bone. I'm asking myself, is this alkaline phosphatase? I mean, I don't know whether we really completely excluded the bony manifestations, because when I think of blasto, like one of the few endemic mycoses that can present in immunocompetent hosts, usually presents with pulmonary skin manifestations. And I know that the skin manifestations are always so diverse that they can even resemble squamous cell carcinoma, or sometimes also looking like molluscum contagiosum like lesions. So yeah, and now seeing, I mean, we were in the autoimmune condition, and now seeing that this indeed came back as a granulomatous infective skin condition. I am mind blown, and thank you so much for sharing this case with us, especially seeing how we were trying to connect all the dots together. And also I've learned so many new facts also with this aseptic abscess, and seeing what also the dermatologists were thinking with. They were initially thinking of something like paraneoplastic, and this coming out as infectious. Wow, thank you so much.
Shayma, I couldn't agree more. I think, Nicole, this is such an illuminating case that allows us to really talk about things that we almost never get to talk about. And I think for me, if I were to do a cognitive autopsy, it's the process that Shayma was doing so well about inventory of the organs that I wish I, not I wish, I mean, I look forward to doing it better next time, but the major thing that my mind overlooked was the dry cough, and to try to get high fidelity information on what that meant. Because if you're thinking granulomatous infection versus neutrophilic dermatoses and you have a dry cough, you really want to explore that cough with high fidelity information like a CT scan, because neutrophilic dermatoses almost never involve the lungs, versus almost all the granulomatous infections, with some exceptions like leishmaniasis, do involve the lungs. And so if we had, the problem representation ultimately was actually a young man with nodular lung manifestations, a splenic manifestation, and skin lesions. And I think that certainly almost completely eliminates the neutrophilic dermatoses, which usually spare the lungs. And so that subtle symptom, I think, was actually the really powerful tiebreaker that would have probably um, given us so much momentum to look up and pursue infections with a high degree of concern, even if the initial biopsies were negative, to see that pattern on the CT scan. And so it's amazing to me how this person's cough, I think, is ultimately the most powerful lead into this case. And I'm humbled as always by Blasto. I've been fooled by it many times, and we'll add to today as another Blasto blasting by me. But I'm curious, Nicole, what were the biggest lessons you learned? I can't imagine, I probably like 100 of them that I can count so far, but what stuck with you the most?
So this was such a case that stumped me, and to be honest, like dermatology scares me a little bit. I am not a very like smart person when it comes to dermatology. So it was a lot of searching on the spot at like 9 p.m. when I was trying to see this patient and come up with something smart to tell the surgeons. I think the biggest things for me were just I have the tendency to like anchor on whatever is told to me. And I think like it was particularly tough in this case because you have like multiple amazing specialists who know what they're doing saying this is a cancer, we're worried about a cancer. And that is probably the biggest, most scariest thing that you don't want to miss. So I totally get why people were like keen to take this guy to surgery, like get this mass out, you know. I agree that I don't think it would have been wrong to like get the skin scrapings and then see what happened. This is just sort of how the case played out in this scenario. And this guy could have maybe kept his spleen. Who knows? There was a lot of blasto in there, though. Looking at the scans, it was quite impressive. I wish I had them to show you. I just can't access my system right now, unfortunately. But I think for me, it was the anchoring that was sort of the big thing. Like for me to take a step back, and like you guys did that from the get-go. I certainly did not do that. So it was great listening to your discussion and just, you know, seeing you guys just be like, wait, is this really angiosarcoma? And like really start to think through your differential, I thought was incredible. And that was the biggest thing I think I took out of this case as I continued to follow kind of remotely.
Yeah, I appreciate you saying that. I think it's really hard to do that at 9 p.m., especially when the case
Yeah.
isn't being presented to you in VMR, where you know that like you have to really cast doubt on everything. And yeah, I will remember this case for a lifetime and all the lessons that it came with. I was just trying to jot down some notes to things to review later. Sohail has the tough task of trying to summarize the learning from this case. I'll pass the mic to you.
Oh gosh, this was a very elucidating case for me because a lot of skin lesions is, I'd say, my weak point. It's not really my strong point, but I'll try to summarize the case for you all. Thank you so much for presenting this case. Great discussion. So we started this case with the cutaneous lesions, examining cutaneous lesions in the context of oncologic history for this patient, the probable splenic angiosarcoma. And the first thing is to characterize the skin lesions, is the appearance of skin lesions. Ulcers may point to a different pathology, such as visceral leishmaniasis, nodular TB. We should also consider whether the lesions are limited to the skin or there's an underlying systemic disease which is presenting with skin findings. And the next step that or the next question that we should ask is whether this is, whether the splenic findings on exam is a mass or is it due to splenomegaly. And there's a broad differential for this spectrum, including infiltrative disorders, oncological, which includes leukemia, melanoma, histiocytic neoplasms, infections, endocarditis, granulomatous disease, autoimmune, such as IgG4 related disease. Um, Leukemia may cause extramedullary hematopoiesis, which can cause splenomegaly. And we also consider the fact that metastatic splenic tumors are unusual and that most autoimmune diseases don't form masses. But I think the key question to ask is whether this is splenomegaly or whether this is a splenic mass. We then got this finding on physical exam of an abscess in the torso in the right biceps and the left shin, draining purulent discharge. And so one of the key teaching pearls is that abscesses in torso tend to be inside out processes rather than outside in. And the most probable cause is due to infection, or we initially considered infection in this patient as the most probable cause due to the pus. And we considered nocardia, leishmaniasis, etc. Especially due to the patient's oncologic history, cancers and infection usually go together due to local or systemic immunosuppression from hypogammaglobulinemia, that's a mouthful, and systemic chemotherapy. But in this patient, it's a little difficult to marry infection and angiosarcoma, although some splenic lymphomas can also cause or make the patient predisposed to infection. But we also considered challenging the hypothesis that infection or purulence always indicates infection. And we also considered that pus is due to infection plus neutrophilic dermatosis, which is a key equation that I will put in the back of my mind. Some of the differential diagnoses for neutrophilic dermatosis include systemic, including Still's disease, secondary Sweets, aseptic abscess, intermediate Behçet, Sappho, and skin predominant, such as sweets and pyoderma gangrenosum. We considered microcytic anemia, or this patient presented with microcytic anemia, and the differential that we considered was iron deficiency or anemia of chronic disease. But we kept that in the back of our minds. And the low albumin, the broad differential for that includes liver inflammation, GI enteropathy, or nephrotic syndrome. Is there additional liver or GI component? We also considered that, but we kept that in the back of our minds. For infection, we went back to the hypothesis of infection, particularly due to granulomatous disease or eczema from staph or staph. Aseptic abscess, we considered that as being a neutrophilic dermatosis of the spleen overlapping with sterile neutrophilic inflammation or autoimmune conditions like IBD. And there's a whole spectrum of these conditions, but when the spleen is involved, that's when we consider aseptic abscess. We treat this with steroids, and surgery would be concerning due to a pathogy, which is a resistance to skin healing due to some sort of systemic autoimmune or inflammatory process. Then the case took a very massive turn, and after the surgery, the pathology came back for blastomycosis, which is a very few endemic mycosis that present with pulmonary manifestations with a variety of skin lesions, and some of them can be even mimics of squamous cell skin cancer. And I think it's important to circle back to the initial presentation of that dry cough, which would pivot to infection as the underlying etiology for this patient's case. Thank you very much. That was a lot of cool skin findings and a lot of mouthful of words.
That was awesome. So absolutely amazing job. You didn't miss a thing. It was so cool. Nicole, thank you. It was such a treat. We've been waiting for your presentation for a long time. I know you had prepared it a while ago, and we're thrilled to have waited for today. It was very enlightening. And Shema, thank you as always. It's a delight. Have a wonderful rest of your day. See y'all later.
Thank you.